I want to introduce our first speaker, and again, one of the great honors that I have with this conference is to meet just incredible clinicians and people doing really interesting things across the country and the world, and then hopefully get lucky enough that we can bring them here every year, which we've been fortunate enough to do. I want to introduce Dr. Jessica Schleider, and she's the founding director of the Lab for the Scalable Mental Health and associate professor of medical social sciences, pediatrics, and psychology at Northwestern University. And she also serves as the director of digital services at Northwestern's Center for Behavioral Intervention Technologies. Her professional mission is to build, test, and disseminate scalable, evidence-based mental health solutions that bridge previously unfillable gaps in mental health ecosystems with a focus on single-session interventions for underserved youth. She's published more than 110 peer-reviewed articles and has also created or co-created 7 open-access, single-session mental health programs, which have reached more than 50,000 people to date. Based on these programs, Dr. Schleider and her colleagues wrote a self-help workbook called the Growth Mindset Workbook for Teens. She also co-edited the Oxford Guide to Brief and Low-Intensity Interventions for Children and Young People. She recently wrote a nonfiction book that's out called Little Treatments, Big Effects, on how single-session interventions can help transform mental health. She completed her Ph.D. in clinical psychology at Harvard University in 2018, along with her doctoral internship in clinical and community psychology at Yale School of Medicine. Please give a warm welcome to Dr. Jessica Schleider.
Good morning. Does this mic work? Yeah, I think it does. Beautiful. Really happy to be here and excited to be able to share some of the work that myself and my lab team of almost 30 folks over at Northwestern University have been doing. So quick shout out, thank you. These are disclosures, but really none of the work that I'd be talking about today would be possible without generous funding and leaps of faith from various organizations that we work with. So really grateful for that support to do this research. Before I start talking about mental health, I want to take a brief interlude to talk about a bridge, architecture. I promise it's relevant, it'll become clear in a moment. So the Choluteca Bridge was a bridge that was built in 1996 in Honduras. And it was built to withstand really severe weather conditions like hurricanes, tornadoes, other things that really plagued the architecture there to date. And it was built using state-of-the-art methods, and in 1998, it was put to the test. There was an enormous hurricane that actually destroyed a lot of the architecture in Honduras, but the Choluteca Bridge survived. Originally, it was built over the Choluteca River. However, flooding from the hurricanes that happened in 1998 were so severe that the terrain surrounding the bridge actually shifted, such that it became a bridge to nowhere. Extremely sturdy, outstanding architectural masterpiece, completely useless because the ground underneath it had shifted. And to me, this couldn't be a more perfect metaphor for the mental health care system that we have today, where we've worked so hard for so long to build something that may work for the few people who manage to get on it, to get into it. But given the ecosystem and the shifting context around it, it simply isn't enough, and we have to be creative in thinking about other solutions. Just to give this a little bit more life, meaningful transformation of mental health treatment, in my opinion, is going to require reckoning with 3 really difficult realities. The first is that about 80% of young people with mental health needs and about 50% of adults with mental health needs do not access any form of treatment, full stop. And those are statistics that have been consistent for decades. And they've only gotten worse since COVID-19. The second reality is that the supports that we do have in many cases are structurally incompatible with how many people, especially young people, want to engage with treatment, which is not necessarily going to a physical office once a week for an indefinite period of time, but people want help, and especially youth want help when they're experiencing difficulties on an as-needed basis, based on their needs and evolving contexts. And the third reality is that despite the wonderful work that's gone on over decades, I'm trained as a cognitive behavioral therapist. I've delivered CBT and DBT and ACT and all of this. Despite our years of research on these multi-session, multi-week, multi-month interventions, we know from insurance reimbursement data across the nation that the most common number of mental health sessions, encounters with care that people actually get, is 1. And that's a number that's consistent in the United States, in Australia, in New Zealand, in Canada, in Spain, in Japan, the list goes on. This is an extremely common pattern that many people are only able to access treatment on 1 occasion, if they're lucky. One commonly proposed solution to the mental health crisis that we're facing is expanding the workforce in mental health care. And of course, that's an important piece of the puzzle. But the provider shortages that we're up against are so extreme across the US that if we miraculously doubled the mental health care workforce overnight, we would still fall dramatically short of meeting the needs of young people especially, but people nationwide. This is a really sad map that you can generate yourself if you'd like to, using publicly available data from the Health Services and Research Administration. The areas in dark blue and medium blue are provider shortage areas, federally designated. Not an error, the whole map is medium and dark blue. That's just the state of affairs that we're up against right now. So given these realities, given the need for transformation and the structural incompatibility of the healthcare system we have with the mental health needs across the nation, the Lab for Scalable Mental Health has a mission to design, test, and disseminate brief and barrier-free interventions to reduce mental health problems on a larger scale than one-to-one psychotherapy was ever built to. To accomplish this goal, a lot of what we focus on are the briefest possible form of interventions, given that they're especially scalable, called single-session interventions, which I'll call SSIs because it's fewer syllables. What are SSIs? They are specific, structured programs that intentionally, and that's key, involve a single visitor encounter with a clinic provider or program. I say intentionally because showing up for an initial intake session but not being able to return due to logistical barriers, not an SSI. That's accidental early dropout because people weren't able to come back. This is a very different mindset towards going into that first session with the idea that you're going to do the most that you possibly can in that encounter. SSIs aren't necessarily, though, a one-and-done kind of support. They're an as-needed form of support. Often they're called one-at-a-time therapies, right? Because they can serve the needs of somebody in the moment while keeping open the door for more sessions in the future, should they be needed at various points, but not assuming how long or short treatment needs to be. They can be self-guided or human-facilitated. A lot of the work that my lab does is on digital, self-guided single-session interventions, which I'll talk about momentarily. And they can be accessed within formal mental health care systems or outside of them, like in schools or even through social media platforms. But in all cases, single-session interventions drop this often false assumption that people always can and always will return for session 2, while instilling the belief that meaningful change is in fact possible, which the research supports, at any moment, however brief that moment might be, and for any person who's showing up for help. So these SSIs are designed to create contexts of competence, assumptions that every human is coming into these sessions with strengths and capacities that allow them to get to where they are today, that will allow them to take a step in a meaningful direction to make change happen. When I was a Ph.D. student working on my clinical psych doctorate, I was working in community clinical settings, school-based clinical settings, and came up a lot against the frustration that a lot of the young people that I was treating were not really able always to come back for multiple sessions. So I started wondering if anyone had studied this. Is there something and some way that you can make one clinical encounter meaningful? And I thought this was a really interesting idea. As it turns out, it was not remotely original. Back in 2017, when I published the first meta-analysis of single-session mental health intervention treatment trials, there were already 50 randomized controlled trials testing mental health SSIs for youth. And this graph shows the results of that meta-analysis, which put together all the results of those 50 studies. On the y-axis, You can see the size of the effect of the intervention. It goes from 0 to just over 1. 0.5 is a medium treatment effect size. The red bars here are the average effects of mental health interventions that last on average 16 sessions. Okay? They're on small to medium effects. The blue bars are the average effects across those 50 trials for single session interventions for the same problems. So those bars are, at the time, I thought they were frighteningly close together. And at first, we were convinced, my then doctorate advisor and I were convinced that there was some kind of coding error and this couldn't actually be the case. But in fact, from a glass half full perspective, it does appear that there is something meaningful and consistent that can be accomplished, even in one session of care. More recently, our lab completed a much larger review. This is now 7 years later. Lots of new work has been done. We did what's called an umbrella review. So we took all the systematic reviews that have ever been done on single-session mental health interventions, synthesized that literature, and altogether we found 24 systematic reviews of SSIs, which included 415 unique clinical trials of SSIs for youth and adult mental health problems. 20 of the 24 meta-analyses or reviews found that SSIs were effective, both for mental health outcomes, reducing symptoms of depression, anxiety, other difficulties, and increasing interest and motivation and use of other forms of care for those who had access to it. 4 of those reviews directly compared single-session interventions to multi-session therapies in a head-to-head fashion. And SSIs were equivalent to multi-session therapies in 3 of those 4 meta-analyses. And the overall SSI effect fell into the small range. This is a graph, and I'm happy to talk all about it if you're interested after this. But long story short, they are significantly, consistently effective at reducing symptoms across periods of 2 weeks to a year, depending on the intervention and the population. I want to emphasize at this point that I am not trying to argue, and I do not believe that SSIs should replace anything that we already have in our mental health care ecosystem. That's not the goal. The goal is to fill the gaps that the current supports in our system are never going to, because they weren't supposed to. They weren't built that way. They weren't designed to reach people outside of traditional ecosystems of support. So what I think is that SSIs can really bridge gaps that are otherwise unfillable in the systems that we have. We've been at this as a lab for quite some time. We've developed a suite of evidence-based single-session interventions, which are all freely available. They've now served more than 70,000 young people, mostly teenagers. Some via grant-funded, NIH-funded studies, but most through nonprofit and community partnerships that we've been fortunate to be able to translate these programs into 8 different languages. 2 of our single-session interventions, which are self-guided online activities that take about 15 to 20 minutes for teens, have been certified as evidence-based and dissemination-ready by a nonprofit called Blueprints for Healthy Youth Development. They've been built by a co-design with and for young people, so we're sure that we're not just building things nobody will use, we're building things, consulting teens at every step to make sure that these are things they actually want. And because we make our single-session interventions, particularly the online ones, available with or without parental involvement, which is, as I'll talk about later, a key barrier to youth access to treatment, most of the young people who access our interventions identify as sexual minorities, gender minorities, or racial or ethnic minorities. So folks who traditionally would have less likelihood of accessing treatment. We have a variety of interventions, all of which are freely available, as I said, through our website, and they each target different kernels of larger, longer-term treatments, like what you do can shape how you feel, behavioral activation. We all have potential for change because of how our brains work, growth mindset. But each SSI targets a modifiable short-term belief or behavior that we know underpins multiple kinds of mental health difficulties. And we know that short-term improvements after these SSIs, and things like perceived control, autonomy, hope for the future, they actually spur upward spirals of change in symptoms of depression and anxiety that we've seen in our randomized trials can last 3 to 9 months later. What goes into an SSI? Well, we've boiled it down to a few different components based on affective science, clinical psychological science, and marketing, actually, to understand what is salient and memorable and powerful in messaging. And the components we've landed on are we use brain science, or scientific principles generally, to normalize the concepts we're teaching and strengthen buy-in to the concepts we're sharing. So it's not just random adults telling teenagers how to think and feel. We share neuroscience principles about neuroplasticity and how the brain can change, and use that to allow teens to learn about and draw their own conclusions about whether and how these skills might help them. Oops. E is for empower. Youth don't have a lot of autonomy or agency in the mental health care ecosystem, so we put youth in the driver's seat from the get-go. They can choose when and where to do the interventions. And they're told from the start, at the beginning of the interventions, you are the expert in your lived experience, and we hope that you can use your lived experience to also not just help yourself by learning things through this program, but also to help others by teaching what you're about to learn to others who are struggling. S is for saying is believing. This is a social psychological approach where you basically learn by teaching. So we give teens stories from others that we've collected about coping with depression and anxiety, and the teens use what they just learned in the intervention to give advice to somebody else about how they would cope. And by doing that, they internalize the concepts we're trying to teach. T is for testimonials, stories, narratives from other teens who've been through things like depression or anxiety and come out the other end. And when you can see somebody like you, somebody like yourself, with an outcome that you may not have imagined for yourself, that's a really powerful thing. It's affectively salient and memorable and really helps with internalization of what we're trying to teach. This is just an overall theory of change that we've tested in a few different trials at this point. So we believe that single session interventions work by tapping into these core tenets of self-determination theory. They help people build a sense of autonomy, a feeling that they can choose their outcomes, a sense of competence. People do action plans in the interventions to take concrete steps in directions that matter for them, and relatedness. So we share these stories, et cetera. And through that sense of relatedness, they feel like they're not alone and they can do it. That in turn leads to declines in hopelessness, more engagement in positive activities, greater sense of agency and motivation. And finally, we see that that in turn leads to reduced mental health symptoms and increased engagement in SSIs and other kinds of services as well. The largest ever randomized controlled trial that we've done of digital single session interventions, we conducted during the COVID-19 pandemic with funding from the National Institute of Health. This was a nationwide randomized trial including 2,452 teenagers across all 50 US states with elevated symptoms of depression based on the patient health questionnaire. That map shows where they were located, so we were really able to reach teens in all corners of the country. In this sample, which we recruited teens for entirely over Instagram, because that's where they are, whether we want them to be or not, that is where they are, and that's where they look for support. So it's really important to put these interventions where teens are actually seeking help. We tested whether 2 digital single session interventions, one teaching growth mindset, the idea that we are all built with capabilities for change simply because of how our brains work, and therefore depression is not set in stone, it's not part of who you are, it's changeable and malleable. And one teaching behavioral activation, the idea that what you do can shape how you feel, therefore depression isn't a state you're stuck in, it's something that you can take small but meaningful steps towards addressing. We tested whether these interventions reduce depression symptoms, trauma, anxiety, and restrictive eating compared to an active control across 3 months. Couple screenshots from the interventions themselves, which are fully completable online on a cell phone or on a computer. We teach about brain science, neuroplasticity, and why that means that everybody has capabilities for change. In the behavioral activation intervention, we have a personal behavior experiment and action plan. We have teens first rate their mood right now on a 0 to 10 scale. We then have them select one of a few different videos. They're now TikTok style rather than YouTube. Engagement is better that way. But they pick one of 3 videos that we've carefully tested for being hilarious or delightful. This one is of a porcupine eating a pumpkin and making the best noises you've ever heard in your life. I highly recommend it, just as a general intervention for everybody. And then right after, we have them rate their mood again. And usually, 95 to 99% of the time, it goes up at least a point. At which point, they get the immediate feedback of, wow, this was just a random porcupine that you watched for 30 seconds, and your mood detectably changed. Imagine if you took the time to connect with people who you care about, do something that is meaningful towards a goal that you have, or just do something just for you because you deserve it for 5 minutes a day. Imagine what that could do for your mood. And we have them make an action plan to do exactly that. And in every single one of our SSIs, there's an action planning component, so people leave with something they can screenshot or email to themselves for exactly how they can take steps in a direction that matters to them. We also have these saying is believing activities where we give people situations that peers are experiencing and ask them to give advice based on what they just learned in the presentation or in the intervention. So in the growth mindset intervention, this is just one piece of feedback that youth gave. We ask, let's say a friend, somebody who you thought was your friend rejected you, and that's really upsetting. How would you help somebody cope with the situation? This teen said, I would tell them to remember that even though it feels like these things will never end, nothing is forever. Maybe by being nice to the kid, you can make him realize that he's being mean, and his neurons will help him change for the better. So they get it. I could spend the entire rest of the hour on these quotes, but I won't. They're wonderful to go through. I want to take a moment because in researching, in clinical trials specifically, it's really important to ask the question, effective compared to what, right? Not any old control group is going to do the trick in terms of convincing us that single session interventions or any intervention actually works. Now, the most realistic comparison to a digital self-guided SSI would be nothing. That's what most people are going to be able to access if they don't get something like this, if they're searching on Instagram for support. But we wanted to show that this wasn't just better than nothing, it was better than a plausible something. So we made a placebo single session intervention. This is a length-matched activity that you can do on your own in 15 minutes that we call the Sharing Feelings Project. And it contains similar kinds of graphics, stories from other peers, but it's designed to control for non-specific aspects of going through an interactive program like this by teaching kids that sharing feelings is good and you should do it. So kind of like generic advice that they would receive if they were having a tough day at school, for example. So it's face valid. Kids do not successfully guess that this is a control condition. They're more likely to guess that this is the active intervention, actually, because this is what they assume therapy is supposed to be. There's no mention of malleability of personal traits like the growth mindset intervention, and there's no action plan, and there's no advice giving, but there are similar levels of interactivity in both kinds of supports. Okay, so what did we find in this 2,452-person RCT? First, we looked at immediate effects, because if you think back to that theory of change that I talked about, how these interventions work is they spark immediate shifts in things like autonomy and perceived control, and then those later lead to shifts in symptoms. So first we looked immediately, and we found that both the ABC project, Action Brings Change, and Project Personality significantly improved hopelessness and significantly improved perceptions of agency, perceived control, or perceived problem-solving ability from pre to post-intervention. But what we really cared about were the long-term outcomes. Did these matter over time? So we checked in again with all of the teens 3 months later. And compared to the teens who got the placebo SSI, teens who got both active SSIs had significant reductions in depression symptoms 3 months later. And the growth mindset SSI also significantly reduced anxiety and COVID-related trauma. We also found that both interventions, as a surprise to us, significantly reduced restrictive eating behaviors, which has led to a whole new line of research on SSIs for body image difficulties. Won't have time to talk about today, but it's really exciting work that I'm very eager to talk to anybody who's interested about. But long story short, this is extremely promising, given that we were comparing it to a pretty robust control, and a 20-minute intervention had effects 3 months later. Because of the diversity of our sample, because we had very open or low barriers to access for our study, we were able to look really carefully at whether there were any disparities in effectiveness for this intervention, because a lot of evidence-based treatments are evidence-based only for those who are able to be in research studies, which typically are upper and middle income white families. And in this study, we found that there were no differences across racial or ethnic lines or by gender or sexual orientation for teens in the effectiveness of the interventions. One question that is important to our team as researchers is, and to me as a clinician, is do these SSIs work better for some people than for others? We have not really gotten very close to answering that. Despite a lot of effort, we've collected data from tens of thousands of people, and despite everything you see up there, what we've come up with basically is a list of things that don't seem to matter for SSI effectiveness. Some of those things are how severe your symptoms are at the start. When I started this work, I assumed light touch intervention, low intensity problems, right? It's going to be better for prevention and early intervention than for kids with more severe difficulties. Not the case at all. In fact, it's the kids who are struggling the most who are most likely to use an intervention like this when they're experiencing a moment of need. Presence of suicide, self-injurious thoughts or behaviors, not connected to outcomes, but is connected to uptake and engagement. Parent factors like parent mental health difficulties or family stress, also not related, potentially because anybody can access these interventions regardless of what's going on in their lives. And unfortunately, receipt of other kinds of treatment didn't impact outcomes. I wish it did. I wish that youth who were getting other services did not need these interventions or did not benefit from them, but that's not what we're finding, potentially because what treatment is can vary so widely depending on where you're getting it and how it's being delivered. One really interesting line of research that my lab has recently started looking into are how do these interventions actually work? What is the experience of them that makes a difference? And what we've learned, and I write about this in my book as well, is that the experience of a turning point or an aha moment during a single session intervention really does seem to matter for how people respond to these. And one of my Ph.D. students, Jenna Sung, did this study on do aha moments impact whether and how people respond to SSIs. So this was a separate RCT, randomized controlled trial, of an 8-minute SSI, they can be even shorter, on loneliness for young adults, which is a massive problem, public health epidemic, as the Surgeon General has stated. When we looked and asked people in this trial, did you have an aha moment during this intervention? About 40% said that they did, compared to only 20% in the placebo control. And people who had an aha moment showed significantly larger decreases in loneliness over 2-month follow-up compared to people who didn't have an aha moment. So there's something about the experience of things suddenly clicking, which I think if you're a clinician, you've seen this happen in session, right? So things just come together for somebody, and they do have a turning point that allows for future growth. Some of the aha moments people talked about. One person said their aha moment was learning that loneliness is not only a feeling, but a signal from the brain, telling us to connect with others. The part where I asked, would I say that to a friend? It was like, that makes so much sense. I felt like, wow, I really do speak badly to myself. So some perspective taking. Multiple parts made me feel like I finally was understood, that I wasn't alone, that I could do this. That's getting at the relatedness piece that we think is important for SSIs. The realization that risk and perhaps even failure is a necessary part of growth. So being able to approach challenges rather than trying to avoid them. And speaking of which, I'm now going to shift gears a little bit and talk about some of our work, not with teenagers, but with parents. Because, it's critically important for teens to have open access to interventions like these, but what's also critically important is to empower parents of much younger kids to be champions for their kids' mental health. Because a 3-year-old isn't going to be able to access care or even detect that they have a need for treatment. So we really need to focus these on early intervention as well. Project Empower stars this hedgehog because the Ph.D. student who co-developed it with me loved hedgehogs. That's the only reason. Also, it's adorable. Project Empower is a single-session online intervention for caregivers of young kids with anxiety. We built it based on research coming out of the Yale Child Study Center and a program that some of you may have heard of called the SPACE program. The SPACE program is a parent-directed treatment for child anxiety that basically teaches parents to be exposure coaches for their kids. The kids don't show up at all for this treatment. It is only with parents, which I think is really cool. And non-inferiority trials have shown that child-based exposure therapy works just as well as SPACE, just targeting parents. So we wanted to see if we could convey some of what SPACE can do in a single online self-guided session. And Project Empower was born. It teaches parents to, instead of accommodating their kids' anxiety, oh, sure, you can stay home from school because you're socially anxious and don't want to, deal with that today, giving into the anxiety, leaning into it, which works in the short term, but takes opportunities for learning to cope away in the long term. Project Empower teaches parents to instead encourage kids to do brave behaviors, to do things that are hard, even though they're scary, as long as they're not dangerous, in order to overcome anxiety. So we wanted to see, compared to general information about child anxiety and treatment, could Project Empower reduce parents' accommodation of their kids' anxiety, avoidance? We also wanted to see if Project Empower could improve parents' ability to tolerate distress. Because the reason parents accommodate much of the time when their kids are anxious and worried is because it's really distressing to see your kid that upset, and you want it to stop. So of course you're going to swoop in and help, and it feels helpful in the moment even if it backfires long term. So we wanted to increase parents' ability to tolerate that distress for long-term gain for their kids. We also wanted to see, does Empower actually reduce child anxiety symptoms if you look further out over time? So we've conducted 2 RCTs on Empower to test these ideas. The first RCT was in 2021 with 301 parents with high anxiety, because as we all know, anxiety runs in families. And what we found was that Project Empower significantly reduced parents' accommodation of their children's anxiety over 2 weeks. It also significantly improved parents' distress tolerance over 2 weeks. So the natural next step was twofold. 1, do we actually see effects on anxiety if we look further out? And 2, is this intervention not just effective for the 301 relatively high-income, well-educated parents who we included in this sample, but in a sample of parents who are least likely to access mental health support? So our second RCT included 137 parents experiencing financial insecurity. And we again found that Project Empower reduced parent accommodation of child anxiety over 4 weeks this time, and significantly improved child anxiety symptoms over a month with a large effect size. This effect size is about what we would see in a full course of CBT, which was really exciting. And at this point, we're beginning to integrate Project Empower onto waiting lists for people who are waiting sometimes months for youth mental health treatment after they reach out. And we're continuing to disseminate through online channels for folks who wouldn't otherwise be able to access care. So, the research suggests that SSIs can help. That's not the whole solution, though, because if you build it, they don't necessarily come, right? We have a mental health care system, but many people can't access it, so it's not enough to know that a potentially scalable intervention works. We have to then take the next step of actually scaling it. And we're trying a whole bunch of things to make this happen. Different strategies, and there is no one answer to how scaling and dissemination is going to be most effective. So altogether, our efforts to date are revealing where and how SSIs can bridge gaps in care and what barriers get in the way. And throughout all of this work, what matters the most is multi-sector partnerships with clinicians, with community champions, with nonprofits, with governments, both city and state, and with industry too. Because there is no way that as academics or as individual clinicians or as individual nonprofits, no one sector has the answer to making the mental health care system one that's democratized and accessible to all. There has to be partnership across these sectors, and that's what our lab tries to do. So this is a list of some of the partners that our lab currently has in our ongoing work to embed single-session evidence-based interventions into and beyond systems of care. Our earliest attempt to scale SSIs was by making them free. And long story short, making things free is not a good implementation strategy. It's nice that they're free, but that's nowhere near enough. But in any case, I do want to share what we built. Project Yes, Youth Empowerment and Support, is our way as researchers of making sure that anybody can access what we have studied at any time. It's really upsetting to say this, but most evidence-based treatments are never available publicly. Once something is studied in a peer-reviewed paper, very, very frequently, that's where it lives, that's where it stays, particularly for digital mental health interventions. Evidence-based interventions often just sit in peer-reviewed papers, which helps nobody. We wanted to change that. So we've created Project Yes as an anonymous open source way and an ongoing program evaluation for us, so we can get feedback from anyone who wants to give it, to make our interventions free for anybody. How Project Yes works is youth, or anybody, we don't collect any identifiers, so literally anyone can go onto this website at any time, there's no login needed. They choose an activity. Right now we have 4 of our SSIs up there for anybody to try in multiple languages. If they want, they can tell us what they think. Pre and post, we ask, how hopeless do you feel? How hopeful for your future do you feel? How motivated do you feel? Did you like this? Did you hate it? What would you change? And you can skip those if you want, but they're available. And then we ask teens, if they are teens, to share their advice based on what they learn in the activity they choose. And we convert their advice after screening it into a text message-like format and put that in our Project Yes Advice Center. So people are actively contributing by using Project Yes to an anonymous coping repository, which you can scroll through at any time. It's pretty uplifting to read all the things that teens have shared. So we've tested out Project Yes in a variety of different partnerships. When Project Yes just sits on our lab website and waits for people to come, doesn't work so well. But when we partner with city governments to embed them into schools and communities, when we partner with primary care networks to offer them as sort of just-in-time interventions for folks who report elevated depression or anxiety at their well visits, then we see it disseminated. Then we see it reaching thousands of people. Most recently, we also conducted a test of Project Yes translated in Syrian refugee youth in Lebanon. And we found that the interventions were effective in that context as well as in the US. As I said before, if we build it, they don't necessarily come, right? So with digital interventions in particular, we really need to go where teens are, not wait for them to come to us in order to make this all work. For that reason, since teens, whether we want them to be or not, are and will be on social media platforms, we developed a partnership with an organization called COCO. COCO is a nonprofit digital mental health organization that contracts with social media companies to embed mental health supports into the platforms. So you don't have to download an app. If you search for something like suicide or self-harm within one of these platforms, COCO will pop up and offer you resources on the spot. Right? So we've partnered with COCO to make our digital SSIs those resources. So they pop up when people search for mental health related terms in platforms like Tumblr, Instagram, et cetera. And in order to embed the SSIs into this context as just-in-time supports based on search terms and behavior, we actually had to reduce the length of our SSIs from about 20 to 25 minutes to 6 minutes. Why did we do that? Because that is how long a teenager will do something on the internet if they're not being paid as part of a clinical trial. There is no scientific reason. It is purely pragmatic, which is how this needs to go. We tried our best to retain the core elements of self-determination theory. We have a very brief action plan. We have a story from a peer. We have psychoeducation, including brain science. And because we've already conducted these thousands of people RCTs, we can compare these Tumblr, Instagram versions to benchmark that against the RCT results. And what we found was that the interventions, when embedded directly into Tumblr as just-in-time supports, in about 6,100 people were just as effective at reducing hopelessness as they were in the larger clinical trial where the interventions were closer to 20 minutes. But the completion rates were a lot higher. Why? Because they were shorter. It's not rocket science. It's just easier, and they can still be helpful. We've also worked with COCO not just to use SSIs as just-in-time interventions for reducing mental health symptoms directly, but also for increasing uptake of crisis resources. When you log on to any social media platform, any of you can do this if you want right now, and put in suicide or something like that to the search bar, you'll probably get something like this. Now it'll be 988, but crisis text line 988, and that's it. That's all you get. And companies are pretty much obligated to do this. It would be a bad look for them if they didn't. But this is really insufficient in terms of suicide prevention, right? Most people who get this pop-up don't use it. They just look at it and say, this is impersonal and not for me, and move on. We wanted to see if an SSI could change that. Because these resources, when people do access them, can be life-saving, right? But if people aren't using them, they can't save lives. So we wanted to see if a 1-minute SSI, to minimize the distance between identifying a need, where people are searching for suicide-related content, and offering them something. We wanted to see if a 1-minute SSI mobilizing people to use crisis resources could actually increase use. This SSI included a 1-sentence narrative from a peer talking about how crisis resources had saved them, some normalizing scientific data, sharing how common suicidal thoughts and behaviors are, and how addressable they are, and how much they can change from one moment to the next, and an action plan where they could choose one of 3 different crisis resources to use. And what we found in an RCT of 355 young people on social media platforms, including Instagram, Facebook, Tumblr, and WhatsApp, we were able to double the rate of using a crisis resource with a 1-minute intervention, from about 38% of people using one of these resources to about 78%. This is now a standard part of COCO's offerings. Whenever somebody on these platforms, if they have COCO embedded in them, searches for suicide, they'll get our 1-minute crisis intervention as well as the resources. Now I want to shift gears a little bit to something that may be directly applicable to all of you who practice in this room, single-session interventions that can be delivered by clinicians. Because digital SSIs are a really powerful tool, I think, for filling many gaps in ecosystems of care, but they're not the whole answer, because a lot of people are still going to want face-to-face support. Does this one work? Yay, all right. We were just getting to the part that's like super useful to you too. The single session consultation is an intervention based on solution-focused brief therapy, which I'm sure many of you are versed in, and I know you heard a little bit about yesterday. I designed that single session consultation originally to address the problem of wait lists, which are ubiquitous and terrible. And wait lists actually cause harm compared to not offering anything at all, which is really upsetting because they're everywhere. So I wanted to see if a 1-session solution-focused brief therapy intervention that capitalized on the initial motivation of somebody first seeking treatment, so instead of saying like, great job asking for help, that's really hard to do, see you in 6 months, saying, okay, great, amazing job asking for help, let's do something right now. We can't do full-term therapy, full-length therapy right now, but we can get you started. Can that be helpful? Can it reduce deterioration among people waiting for services? And can it actually make people feel better? This is an extremely easy intervention to deliver. I designed it to be deliverable by anybody, not necessarily people who are licensed providers, but by peers, anybody who's motivated and completes our 1.5-hour treatment. And so far, we've trained about 300 people to do this intervention, including nursing students working on their BSN, peer supporters in Uganda, as well as licensed mental health professionals. This is the intervention. This is the whole thing. It is a two-sided worksheet that if you fill out, then you have done it. It's designed for simplicity. This is publicly available, so I appreciate the photos, but you can download it. And so it's hard to get wrong. This also serves as a fidelity tracking tool. So you can upload this into the medical record that you use, and how we use this in our research studies is we can tell if somebody delivered the intervention correctly based on their answers on this worksheet. What we've found in several trials at this point is that the SSC can be helpful. In one trial of folks on waiting lists, we found that people who received the single session consultation, which by the way was taken up by 75% of people who were offered it, saw a significant reduction in hopelessness, significant improvements in readiness for change, and actually reductions in anxiety and depression over 2 weeks while they were still waiting for treatment. Okay, I can walk around again. Even though the trend you usually see while people are waiting for care is getting worse. So we were able to reverse that trend. Another example, recent example of the SSC in action is a collaboration we have with a wonderful organization that works in Zambia and Uganda called Strong Minds. There's a massive mental health provider shortage across African countries, especially sub-Saharan Africa. And so Strong Minds leverages trained peer supporters to provide interpersonal psychotherapy for depression to reduce the burden there. However, they have really long wait lists because there also aren't enough peer supporters and people need help now. So we adapted the single session consultation for the cultural context there, made it into a group intervention because that's the context that people in Uganda wanted to use it. They really liked the sort of collective support aspect and tested it out on people who were waiting for longer term therapy at Strong Minds. I can explain this graph. It's a lot of lines because each line is a human. This is in our pilot with 200 plus people in Uganda, all of whom had clinically elevated depression based on the PHQ-9. We found that most people who received the single session consultation no longer met criteria for depression a month later. And what you're seeing on this graph is total PHQ-9 scores. A cutoff of 10 on the patient health questionnaire is typically used to indicate moderate depression symptoms. So that red line is at the 10 mark. Everybody had 10 or more at the start, and the vast majority of people had less than 10 at the end. So now the SSC is standard practice in Strong Minds, and we were able to show that peer supporters could both deliver this and that it could be effective. We're working on creating more streamlined pathways for embedding things like the single session consultation into systems of care in the US, but it's really hard because insurance doesn't work this way. You usually have to have a diagnostic code to treat somebody, right? But if you spend the first session on a 3-hour intake of a psychosocial or biopsychosocial assessment, you don't do an intervention, you just collect information from people and then they can't come back necessarily. So, we have worked with state mental health agencies so far in Pennsylvania and Connecticut to secure waivers of the typical requirement for publicly funded, Medicaid-funded clinics to do that biopsychosocial at the beginning so that the SSC can be offered and billed through Medicaid before people formally start treatment and without a diagnostic code. So we're currently testing this across 9 clinics in 2 states. We'll see how it goes. If this works, if we can show cost effectiveness and clinical effectiveness in these 2 states, we have tentative sign-on that these codes will become permanent, which may open the door for use in other states as well. So I talked a lot about what we're doing in terms of scalability, and what I'm really excited about in the work that we're doing and what I've talked about is harnessing the science of dissemination and implementation for deploying SSIs at scale, particularly for people facing structural barriers to treatment. So dissemination and implementation, by this I mean Dissemination is increasing awareness, demand, and reach. People don't know what SSIs are, they won't look for them, right? So that's going to take outside and within healthcare system efforts. And implementation, increasing real-world use and integration, is going to include training of clinicians and the development of platforms that are user-friendly and easily accessible for people to use SSIs where and when they want. But this together still won't be enough, because we also have to pay attention to the structural barriers that may get in the way. Things like parent consent policies. For example, if a youth is going through their social media feed and they see an SSI and they have to get parent permission to use it, zero teenagers will ever use that intervention, because they're not going to ask, especially if they don't feel comfortable talking about mental health with their parents. So what I want to share now is work that we're doing to get at these structural barriers. In multiple studies at this point, when we interview teens who take part in our research studies and ask them what has gotten in the way of accessing mental health care when they've needed it, overwhelmingly, the most popular answer is their parents. This is upsetting, but what we find is that teens it's not necessarily that that their parents would actively reject the idea of mental health treatment, although that does come up. It's that they don't want to burden their parents with worries, right? They know that therapy is expensive. They know that it would create stress in the household, and there's already a lot going on, and they don't want to add to it. For other teens, they don't think their parents would understand, particularly for sexual and gender minority teens or racial or ethnic minority teens. It's something that they're scared to bring up because of either stigma within the household or because of lack of acceptance for identities they hold. So right now, we have grants from the NIH Office of Science Policy and a wonderful org called Hope Lab to explore teens' perceptions of these parent consent policies that in about half of states in the US prevent teens from accessing treatment independently. So the laws, the legal landscape for this is really challenging. And we're really excited to be doing this work to hopefully inform policy reform that can allow teens to safely access evidence-based tools when they want it and when they perceive needs, rather than having these barriers that are really impossible to circumvent in many instances. Another way that we're focusing on dissemination, implementation, breaking down structural barriers is there's actually a really big community of folks doing single-session therapy and single-session intervention work. And next summer, my lab is hosting the 5th International Symposium on Single-Session Therapies. It's next June. It's in Chicago. It's really nice there in the summer. And it'll be a forum for folks across sectors, like I've been talking about, to share how implementation has gone for single-session approaches and what we envision for integrating this into the future. And finally, at some point, I realized I was only talking about this stuff to researchers and clinicians, and I wanted to make the information more accessible because I think that's a necessary part of making SSIs and SST a more widely known concept. So Little Treatments, Big Effects was my attempt for science communication to help this spread and hopefully figure out how to meaningfully expand our mental health care system in a way that matches what people need, where they're at, and the resources that are available to us. So I don't think we have too much time for questions, so if you do have them, I really like talking about this stuff, so I'm more than happy to. There's a book signing after if you want to stop by and say hello. But just huge thanks to everybody in this picture and many who aren't presented. My lab, this is all a huge team effort. And those are links where you can access everything that I talked about, all the interventions and materials. Thank you so much, and I hope this was helpful.